Dr. Piepoli, are you online? Can you hear me? Yeah, probably you are muted. My name is González Juanatey. I am the chief of the cardiology department in the University Hospital in Santiago de Compostela. And first of all, I would like to thank you for accepting the invitation to give this lecture regarding the new European prevention guidelines. A lot of novelties in such guidelines regarding the risk stratification, also the clinical management of the patients, and so we will be very happy to get you on board in this session discussing the new European guidelines. Dr. Piepoli is the chief of the cardiology department in the Piacenza University Hospital. Also is in charge of the heart failure unit, and he is in charge in several positions in the ESC, is the current vice president of the ESC and editor-in-chief in the very prestigious journal, one of the most prestigious journals in Europe, that is the European Journal of Prevention Cardiology. So thanks for accepting our invitation to give this lecture. And at the end of the presentation, we will have some time for the debate. So thank you for accepting our invitation, and we start the meeting with your presentation.
Thank you. The honor is mine, Professor José Ramón González, and thank you, Dr. Sergio Cinza. I'm sorry not to be able to join you in person in Santiago, and hope next time I will be with you. This is my declaration of interest. As you rightly said, the latest guideline on cardiovascular disease prevention has been quite debated, and I think they provided a great advancement with respect to the previous one. The previous one, as you may remember, were published in 2016. I had the honor to chair the 2016 guideline, which, as you know, are prepared on behalf of European Society of Cardiology, but with the contribution on 10 societies involved in cardiovascular prevention, including atherosclerosis, diabetes, hypertension, general practitioner, sport cardiology. So this is really a joint effort of different expertise involved in cardiovascular disease prevention. And this is also quite important that the messages coming from these guidelines are well perceived by the community, whatever community or not only cardiologists, but internists, geriatrician, general practitioner, but also whole healthcare provided involving in prevention. So this is just to remind you what were the previous 2016 guidelines, which were recommended, and they are still recommended, the importance of smoking cessation, healthy diet, which is mainly Mediterranean diet, physical activity, at least 150 minutes a week of moderate aerobic physical activity, or at least 75 minutes a week of vigorous activity, a healthy body weight, BMI between 20 to 25, blood pressure, very straightforward. In 2016, we decided to keep a very simple, below 140/90. We'll discuss later in the guideline, as well as the lipid, which were LDL cholesterol was perceived as is still perceived as a major primary target differentiated according to the risk of the patient. For very high risk, the OP in general patient would have had already a cardiovascular event. We have to be very strict with reaching a target below 1.8 millimole per liter or less than 70 milligram per deciliter, or a reduction at least 50% if the baseline value was already near this target. For the high-risk individual, a target was decided to less than 2.6 or less than 100 milliliter per deciliter, or a reduction of at least 15% in case the baseline was near the target. And for all other individual, usually healthy individual, a target of less than 3 millimole per liter, which is 150 milligram per deciliter was recommended. For LDL cholesterol, HDL cholesterol, no target, but we know that the higher above 1 millimole, which is about 40 milligrams per liter in men, above 1.2 millimole per liter in women, indicate a lower risk, as well as triglyceride, no specific target, but less than 1.7 millimole or less than 150 milligrams per deciliter indicates a lower risk. As well, for diabetes, HbA1c below 7% or below 53 millimole per liter is recommended. It was recommended. Well, what is the problem? What is the guideline? The guidelines usually are very well written, very well perceived, but poorly implemented in the current practice. As you may be aware, the guidelines were proposed to perform, to identify whether they are or not implemented in clinical practice. And the European Society of Cardiology have been developed in the last 20 years a program of survey of all audit of what the recommended target are reached by the population at high cardiovascular risk, which is called, in other words, the proportion of coronary patients achieving lifestyle, risk factor, therapeutic target for cardiovascular disease prevention, defined by Joint European Society of Guideline on Cardiovascular Disease Prevention. And as you know, the first prevention guideline have been developed almost 30 years ago in 1994. After the first recommendation, the first EuroSPI program was developed, and the second Joint Task Force recommendation, which were developed at the end of the 90s, were followed by the EuroSPI 2 and then EuroSPI 3 in 2007 after the third Joint Task Force. After the fourth and the fifth were followed by EuroSPI 4 survey, and also the latest guideline were followed by EuroSPI 5. So this is a good way to assess whether what we are recommending are really implemented in the real life. Well, as you know, this is very unsuccessful. We have been very unsuccessful. This is a comparison of the prevalence of raised blood pressure, elevated LDL cholesterol, and diabetes with respect to guidelines. We're comparing EuroSPI 2, which were performed 20 years ago, to EuroSPI 3, which are performed in 2007, to EuroSPI 4, which are performed 10 years ago, and EuroSPI 5, which has been more recently performed. And you can see in the last 20 years, only half of our population has been able to reach recommended blood pressure target. There was some improvement, but still 1 out of 2, more or less, are not reaching. For the lipids, you know, LDL cholesterol, we have been more successful. Probably also the available new drugs like statins, ezetimibe, particularly, has been able to increase the number of patients at target from 4% to 20 years ago to almost 30% nowadays. But still 1 out of 3 is not able to reach recommended guideline, which I just remember was a target, which is 1.8 millimole. For diabetes, you know, because it's reflecting an increase in obesity, the story is even worse. A significant increase in obese and diabetes people is present all over Europe. So the problem that the task force was trying to face and to tackle was how to make recommendation for preventive cardiovascular disease in both primary and secondary setting more feasible, more effective. So we got the problem, and this was a proposition for the solution. So what is new in 2021 prevention guideline? In order to overcome this barrier in implementation, the task force decided to make several changes. First of all, a stepwise approach and individualized prevention program has been proposed in the new guidelines in order that the individual step by step is accompanied to reach the recommended target for each goals. Also, the risk stratification, which was, as you know, the score one, has been updated. Score one was based on individual, which was from 40 to 65 years of age, which of course is a limitation. It was taking as a target at 10 years all fatal cardiovascular event. So the decision was to extend the risk stratification to all cardiovascular events, fatal and non-fatal, and furthermore to make it more individualized, more appropriate. Europe has been divided in 4 geographic risk with increasing risk. We'll see that Spain has been able to distinguish himself as one of the with a lower cardiovascular risk still. Other important point that was as you know, the major cardiovascular risk at the end of the day is age. Age have a very important impact when you stratify patient. In other words, if you just take age, all young people by definition are at a low risk, and old people are by definition at high risk. But we know that we have to start effective prevention guideline even in a younger population. So this is the modification and the proposition of a new age-specific risk is an important step forward. Another important point is the estimation of lifetime cardiovascular risk and treatment benefit. This is an important also to increase awareness and participation of the individual to the implementation of the guideline. Guideline also put an important point about how all our decision should be shared with the patient by taking into consideration patient-specific condition, here or her prevalence, cardiovascular risk, and treatment to account. You will find also some recommendation on an environmental issue. This, as you know, is very important, and that will be even more important in the future. And signaling of potential cost issues are all taken into consideration. So, to go into detail, this is one of the summary figure of the guidelines, where it is summarized that the cardiovascular prevention should be performed in 2 different settings: at individual level and at the population level. And at individual level, you have to consider primary prevention in apparently healthy people and secondary prevention in patients with established atherosclerotic cardiovascular disease, where a more aggressive approach is recommended, as well as diabetes, familial hypercholesterolemia, or kidney disease, setting where a specific approach is needed. And on the other side, which is complementary with the individual level intervention, is the intervention at the population level, because we realized that any intervention is only effective if it is performed in healthy environment. If you want to promote healthy diet, if you want to promote physical activity, you have also to create city condition that patient can improve and can implement your recommendation. And as well, information as on environmental issue has been pointed out. Of course, important or cost effectiveness must be taken into consideration. So, recommendation cardiovascular risk assessment. Who should be stratified? Recommendations are very clear. So, all individuals which are exposed to a high risk should have a systemic cardiovascular risk with a very high strength of recommendation. As, for example, patients that we know are exposed to smoking, their family history of premature cardiovascular disease, or have exposition of cardiovascular risk factors like smoking, arterial hypertension, and so on. While there is no evidence for a strong evidence for a systemic, but still may be considered a systemic opportunistic cardiovascular risk assessment in the population of men above 40 years of age and for women above 50 years of age, or anyway, after menopause. When your patient has been started in cardiovascular risk assessment, this should be repeated regularly. The guideline recommended at least every 5 years. Why? And the opportunistic screening of blood pressure should be considered, is recommended in individual at risk of development of hypertension because of, for example, they are obese or because of a family history of hypertension. Interesting, there is no indication, there are no evidence at least, there are no indication to do a systemic cardiovascular risk assessment in young patients, with young individual, not patient, healthy individual, at below 40 years of age for men or below 50 years of age for women, because there is no evidence that it is effective. So this is another important summary table, which highlight the importance of a stepwise and personalization approach. We have to identify whether, according to guideline, is recommended to follow a step-by-step approach. A first step where individual should identify the prevention goals, healthy lifestyle, smoking cessation, first of all, estimation of cardiovascular disease risk, of course, for healthy individual, identify treatment goals. But after we have reached treatment goals, we should not be satisfied. We have always to consider a second step where intensified prevention is needed. Also, a more strict treatment goals are recommended. So this is just to identify. So characterization of the individual according to their characteristics, individualized an intervention in healthy people, patient with cardiovascular disease, patient with diabetes or with chronic kidney disease and familial hypercholesterolemia, where prevention goals should be considered and implemented in this individual, but we should not be satisfied with step one. Then a step two is recommended. And this stepwise approach has been felt as an opportunity to reach higher percentage of patients at target. Another important point of the new guideline is the estimation of lifetime benefit from an intervention for a treatment, which is of course based on two aspects: age and risk level. This table should help also the physician and also the individual how is important implementation of intervention. And this, the lifetime benefit is directly correlated, for the intervention, is directly correlated to the risk level. Higher is the risk, higher is the benefit of your intervention, and inverse correlated to age, because we know if you're older, the lifetime benefit cannot be as extensive as you can have at a younger age. Just to give an example, this table are divided according to this, for example, for the benefit of free lifetime from smoking cessation in years. divided by gender, women and men, divided by age, from, as you said, from 40 to more than 90 years of age, and divided according to the risk of the individual, which is related to systolic blood pressure from 100 millimeter to 180 millimeter, and to the lipid to express a non-HDL cholesterol. And then you can see, for example, there is a gradient of a benefit of intervention, which is based on the fact that the higher is the risk, higher is the benefit you can reach. For example, from 2 to 3.4, with the gradient related to the increase in systolic blood pressure to increase in cholesterol. On the contrary, higher the age, lower is the benefit. The benefit you can have on a younger individual, in this case, for a woman with high cholesterol, with high systolic blood pressure, stopping smoking associated with the improvement or the increase of time span of 5 years on the older individual, of course, is less evident. Another example in this way is the time benefit when you want to treat LDL cholesterol. As well, is the same message. There's a gradient. Higher is the risk, higher is the benefit. The higher is the age, the benefit is less evident. In this case, of course, patients are not stratified only on cholesterol, on systolic blood pressure, on gender and age, but also on smoking status, smoker versus non-smoker. This is important because this can have a strong impact also on the young individual to show how the benefit they can reach by controlling their risk factors. So, starting about healthy individual. Who are the healthy individual? So, are the person without established atherosclerotic cardiovascular disease, individual without chronic kidney disease, diabetes, or familial hypercholesterolemia, because these are considered anyway at higher or very high risk. So, following, as you said, that we've mentioned before, by step-by-step approach, starting with the first step is prevention goals for everybody, which are, of course, are healthy lifestyle, stop smoking, and systolic blood pressure, interesting, at least below 160 millimeters of mercury, which is, these are recommended target for everybody. Follow this. Oh, sorry, there was also the opportunity, and I cannot go further. But anyway, stop the importance of next step is the need to identify according to each individual which score according to the score 2 or score OP must be implemented. But we don't know just based on the score. We know that also we have to take into consideration risk modifier or risk qualifier that, especially in this condition of individual which are near the target or near the threshold, should help in identify whether individual should have a more aggressive or even a less aggressive approach. This is score 2, a score 2 OP. You see that what is the novelty? You see that the individual are risk stratified according to gender, to smoking habit, to cholesterol, non-HDL cholesterol, and systolic blood pressure. Of course, there is a gradient from the top to bottom to top, to the left to the right, which is associated with higher risk, so a more important risk stratification, risk intervention is needed. Of course, as we mentioned before, the most important risk factor at the end of the day is age. But the important news from this guideline that even a younger individual, because he is a smoker, because he has high blood pressure, his lipid is under control, maybe a very high risk, and may need immediately a pharmacological intervention. This is very important because this also can give also idea each individual if they reduce any of these risk factor also, because they reduce lipid, they reduce systolic blood pressure, or they stop smoking, their situation can get from very high risk factors to low risk factors, low risk condition. We mentioned before about the importance of personalized therapy, personalized risk stratification. And then the new guideline, with respect to the previous guideline that divided Europe in low to high risk, decided appropriately to divide Europe in 4 risk categories. And those are low risk, at moderate risk, at high risk, and very high risk. Also in this case, you see a gradient from west to east, from south to north. And I'm glad to say that in your country is still at low risk. I'm less happy about my country, that is instead has been devaluated in the middle moderate risk. Of course, there are different specific charter according to different condition, different countries. But why are so important this risk stratification? First of all, there is one aspect I like to draw your attention. As you mentioned, cardiovascular risk threshold are not the same for young and elderly individual. For young individual, you have to be more aggressive. You are considered just a risk threshold above 2.5% is a medium risk, and above 7.5% your individual should be considered at high risk. Instead, for older individual, a 7.5 is the threshold to become a moderate risk, and at least 15% you should be considered at high risk. And this is also get a reflection, a consequence on the recommendation. Individual at low to moderate risk should be advised to keep themselves at healthy because they are in healthy condition, while the individual at high cardiovascular risk or very high cardiovascular risk, treatment should be considered or recommended for the individual at very high risk. So, when we mentioned before, we discussed about prevention for all goals. We discussed about estimation of cardiovascular risk, and that are personalized according to the age of your individual. But at this moment, we have to take consideration, as I mentioned, the risk modifier. Risk modifier, which are related to factors that can better stratify your individual. The presence of risk modifier can increase the risk of your individual, and you may decide to be more aggressive, but the absence of this modifier can reduce the risk of your individual. It can be more cautious, less aggressive. Interesting, also you have to consider lifespan cardiovascular risk, the treatment benefit ratio, and also the guideline recommend also to take into consideration patient preferences. I'd like to also draw your attention that for older individuals, not only this factor should be taken into consideration, but also comorbidity, frailty, polypharmacotherapy, which are very important in older individuals and may affect your decision. And then, based on this, step 1 goals should be implemented. So, which are risk modifiers? Well, there are several risk modifiers, but very few have been tested appropriately and then it can enter in the guideline. Definitely, stress symptoms, psychological stress are one of them. It should be considered. Also, imaging like calcium score, the coronary calcium score as well it may be considered, as well plaque detection by carotid ultrasound is an alternative where calcium scoring is not unavailable. Also, we have to take the ethnic group. We know that the risk in multiplicity of ethnicity that we are fortunate in Europe is we have to also consider. We know that risk should be increased by 1.3, about 1.7 in individual coming from Pakistan or from India, while the risk can be reduced in individual coming from Africa, for example, or from China. Important, and this I think is important to consider that some markers are not being clearly demonstrated to be useful. For example, genetic score, circulating or urinary biomarker, or vascular test or imaging method like intimate media thickness. It doesn't allow us to improve our risk stratification in our patient. So based on all this step-by-step intervention, we can identify the goals. Of course, individual at a low or medium risk, non-additional prevention goal are recommended, but in individual and medium to high risk, a systolic blood pressure target below 140 or 130 if tolerated is recommended, associated with the LDL cholesterol target below 100 milligram individual between 50 and 6, between 50 and below 69 years of age. For individuals at higher age, as you mentioned before, if they are low risk, no additional prevention goals should be considered, but individual at high risk, the same recommendation target for systolic blood pressure and LDL cholesterol are recommended or should be considered. Okay, but can we be satisfied by this step one? No, the guideline recommend to take a second step only, consider to identify treatment, of course, taking into consideration the residual cardiovascular risk, the benefit to harm ratio, presence of comorbidity, frailty, and of course also take into consideration also patient. In this case, a systolic blood pressure below 130 is recommended, as well as LDL target below 70 milligram for high risk, below 55 milligram for very high risk should be considered. These are also the target that have been recommended by the latest atherosclerosis ESC guideline published in 2019. So, just to give some example, these are recommendations for pharmacological LDL cholesterol lowering in the younger individual below 70 years of age. Of course, in this case, in patients with established cardiovascular disease, LDL cholesterol reduction at least 50% or below 1.4 millimole per liter of 55 milligrams is recommended. While if the goals are not achieved, the maximum tolerated dose of statin in combination with ezetimibe is recommended. But for primary prevention, the PCSK9 inhibitor are receiving a recommendation may be considered. For individuals at older age, you can see that treatment with statin is recommended, but initiation of statin treatment for primary prevention in older individual aged above 70 years may only be considered if at high risk or above. Starting also at low dose. Lenient approach has been recommended by the guideline in the individual at a higher age. So go to the patient with the established cardiovascular risk. So these are patients what are the definition? Should be individual with documented cardiovascular disease, including after MI, after Cook coronary syndrome, after coronary vascularization or other arterial procedure, stroke, TIA, aortic aneurysm, or peripheral artery disease, or individual with unequivocal on imaging cardiovascular disease, including plaque on coronary angiography or carotid ultrasound. Of course, it does not include some increase in continuous imaging parameters such as intima media thickness, because that has not been demonstrated to clearly stratify our patient. So in this individual, a step-by-step approach is recommended based on stop smoking, lifestyle recommendation, a strong target regarding systolic blood pressure below 40 or even 30, below 30 if tolerated, as well as LDL reduction below 1.8 or less than 70 milligrams. As also antithrombotic therapy is recommended. Of course, in case we should not stop at this level, also a more strong and more strict recommendation should be always considered as a step 2. What about policy intervention at population level? This is taken into consideration, and the policy population approach to physical activity, diet, smoking and tobacco use and alcohol, in governmental restriction and mandate, media education, labeling and information, economic incentives at school, in workplace, and in community setting are recommended in the guideline. Also, as an important recommendation, putting in place measures to reduce air pollution, including using particulate matter emission and gaseous pollutant, or use of fossil fuels, and limiting carbon dioxide emission are recommended to reduce cardiovascular disease mortality and morbidity. Of course, I'm not going into detail, but also individuals with diabetes, chronic kidney disease, familial hypercholesterolemia receiving a specific attention. I just draw your attention regarding diabetes. Diabetes, of course, as an individual, a step-by-step approach is proposing stopping smoking and lifestyle intervention is highly recommended, as well as reaching HbA1 target below 7% of 53 milligrams per mercury, millimole per mole, and as well as furthermore, your patient should be stratified according to the presence or not of end organ damage in case of without risk of should be stratified according to the risk. At the moderate risk, not further intervention are generally recommended, but high risk and more strict intervention for systolic blood pressure and LDL cholesterol are necessary. As well, this apply also for the individual, absolutely for individual with established cardiovascular disease and diabetes. But we don't have to be satisfied. We have to go anyway to the step 2 approach based on cardiovascular disease assessment, lifetime risk-benefit evaluation, cardiomorbidity, frailty, and patient preference should be evaluated, and more strict target for systolic blood pressure, LDL cholesterol are recommended. And for a patient without cardiovascular disease, SGLT2 and GLP-1 receptor agonists are proposed. but in case of cardiovascular disease, these drugs are recommended, as well as intervention like dual antiplatelet therapy may be considered. So, in conclusion, I hope I've been able to explain or present or discuss to you at least what I feel are the new in the 2021 cardiovascular guideline. The effort from the task force was to try to make it feasible, applicable to guideline clinical implementation. So a new risk stratification score has been proposed, a score to OP, in order to overcome the limitation on the old score 1, with now it is a 10-year risk of all cardiovascular event, taking into consideration not only fatal but also non-fatal event, divided for 4 geographic regions, and a more personalized approach and a stepwise approach to individualized cardiovascular disease prevention, taking into consideration age-specific risk in apparently healthy people, estimation of lifetime cardiovascular risk, and then treatment benefit as an option of intervention, and the importance of shared decision, taking into consideration specific patient condition, his or her preference, and cardiovascular risk and treatment into account. Thank you for your kind attention.
The guideline. First, I like to know your frankly opinion regarding the step approach for the risk control, at least in patients in secondary prevention, in very high risk patients. These new guidelines incorporate this two-step approach. The first step is reducing blood pressure and reducing LDL, and then you can consider a second step. What do you think about the possible impact of this new recommendation in the guideline regarding the Aerospire results, Aerospire impact, at least in secondary prevention? I'd like to know your opinion is focused on secondary prevention patients with a previous ischemic heart disease. What do you think about the possible impact is the two steps approach?
Well, of course, I appreciate the effort of the task force in order to make more feasible, more practical in the clinical practice, reaching the target for our patient, in order to not discourage if the individual doesn't reach the highest target, in order at least to reach a lower target. On the other side, on the other side, we know from the clinical experience, from scientific evidence, that if we don't reach the most strong, the more aggressive target, we probably are not successful really in impacting, in reducing cardiovascular the consequences of cardiovascular disease, particularly in secondary prevention. I think also we have to see to guide from experience. I think it's also important, at least from my modest experience, which patient you have in front of you. Some patients are very keen, are very proactive, and they are really interested in collaborating and working together to control the risk factors and in evaluating regularly to reach our target. Other individuals are very difficult, and then and unfortunately, at least in my experience, is the majority. And I think a more progressive approach, more personalized approach, is maybe more effective. And I know this. I know the criticism that this may arise, but on the other side, we know from Eurospire till now will be poorly successful. So at least it is an attempt to make guideline more really feasible in clinical practice.
I have a question, Professor. Professor Piepoli, good afternoon. I am Sergio Cinza. We write by email these days. I have a question of a practical point of view. In really, the guidelines say that we have to begin with a statin to up the doses and then use a ezetimibe. In the very high and high cardiovascular risk patients, maybe it would be better to begin with a convenient treatment as the same as in hypertension and now in diabetes.
Yeah, I agree, but at least in my, I can just bring my experience, Dr. Cinzia. I usually start in the secondary prevention with high dose of very high effective statin usually, and then to see whether what is the response in reducing LDL cholesterol, and I use ezetimibe if I beside the high dosage of statin I'm not able to reach the target, and leaving a PCK9 just a latest resort, also because their costing till now is still very elevated, and we have also to consider this in the global consideration, unfortunately.
I would like to know your opinion regarding, I think in these guidelines, the role of cardiac rehabilitation is not so reinforced. It's mentioned, obviously, during the test and the narrative of the guidelines, but do you think that the emphasis on cardiac rehabilitation, particularly also in secondary prevention, would be more focus or be more stress recommendation in the guidelines? Because reading the guidelines, the cardiac rehabilitation is not so clear, the big role, particularly as I mentioned in secondary prevention. What do you think about the role of cardiac rehabilitation in these guidelines?
Well, this is an important point. In the previous guideline, we spent a little bit more part in discussing about cardiac rehabilitation in different settings. We were discussing about also home-based versus central-based or hospital-based or even nurses' home. In this guideline, this probably also task force, of course, the guideline reflect also the philosophy, the composition of the task force. In this case, the component of cardiac rehabilitation, clinical cardiology and cardiac rehabilitation was less strong and less present to discuss. I agree with you. The importance of secondary prevention, cardiac rehabilitation, secondary prevention should have been a little bit more underlined and confirmed in this guideline. It's a good point.
We have a question with a follower online with the Dr. Prieto. He said about the use of stratification cardiovascular risk tools, if he considered the pre-diabetes situation should be included as a cardiovascular risk factor, because maybe these patients have more risk than the healthy people.
Well, this is interesting point. The pre-diabetic condition has been always debated in the guideline. Also, at the end of the day, if this individual got elevated glycemia and elevated HbA1c, we are considered at a risk of we are considering it as similar to diabetes in general, without considering pre-diabetic, because also it's difficult definition. Also, there was also some consideration about pre-hypertension or moderate hypertensive. At the end of the day, the approach was to keep it simple, and then to say if the individual has got impaired glucose metabolism with the elevated HbA1c, is considered diabetes, and less strength and less interest has been focused on pre-diabetes.
Okay. There are other questions. The first one is the inertia in treatment is a problem for us in primary care, for example. The two-step approach will not worsen the situation.
Well, inertia can be from different reasons. Could be us as a physician not good enough to explain, or we are not good enough in prescribing, because for several reasons. Because of the patient doesn't want to take, because the healthcare system doesn't help us providing enough time, enough setting to where to visit our patient, because sometimes, especially in secondary prevention, we are obliged to discharge patient very quickly to keep hospital stay very short. So there are several aspects that are making, of course, in my opinion, is a matter of the culture, education, diffusion of the knowledge, the importance of this conference, like what you are doing in this aspect, I think play a crucial role, because in this way, this opportunity between different speciality, different expertise are putting together and combine their experience in order to overcome this limitation. So I have to congratulate you, because at least from my point of view, is the best way to overcome this inertia.
Okay. And this is the same with the dyslipidemia, because this doctor followed the question and said us that the Eurospar 5 tell us that we did not reach the objectives in the guidelines. Shall we change these two steps and only use one step to reach the objectives better?
Well, that could be also an option to see whether step by step how the guidelines are incremented. What step one and step two. This could be a very important advice to be evaluated how the guidelines are effectively implemented in the clinical practice. I agree.
Thank you.
So thanks. I think it's a very interesting debate, particularly taking into account that was previously to your presentation was discussing some facts in Europe and particularly here in Spain, probably also in Italy, that the Eurostat informed this year, and the first months of this year, the mortality, cardiovascular mortality in Europe and particularly in our countries was an expected increase regarding compared with the period pre-pandemic period 2016 and 2019, and was also suggesting that the loss of the follow-up of many patients and the loss of the prevention programs may play some role in its unexpected increase in cardiovascular mortality in our countries. Probably your lecture regarding these prevention guidelines can help us to thinking how to reorganize the prevention from primordial prevention, primary prevention, and particularly how reorganize secondary prevention, very high risk and high risk patients follow up. Otherwise, we can continue to see an unexpected increase in cardiovascular mortality in our countries. And for me, it's one of the biggest challenges in Europe, how to overcome this crisis after the COVID pandemic regarding this fact. I think that a debate like this debate, according to the guideline recommendation, may help us to think as health professionals how to overcome. So thank you, Massimo, for this lecture. We await for you here in Santiago. You will probably come visit us in a near future. Thank you very much for your collaboration, and thank you very much for your friendship.
Yeah, thank you very much. I'm sure what your observation about Eurostat is data is very, very really alarming. Of course, I'm sure a lot of our healthcare resources has been diverted towards this pandemic. Of course, I think also there is should be looked really into detail about because this is really worrying. Of course, obesity is increasing, diabetes is increasing, sedentary habit, unfortunately, is increasing, at least in our region. So this also unhealthy lifestyle is really a big part that we should take into consideration. Thank you very much for your very, very kind invitation.
So thanks.